Hello, Gifty. Gifty.
Sister,
You let me. Good morning, class.
sister,
Good morning,
Good
sister.
morning. Good
Gifty, is
morning,
it that
sister.
the group presenting are not ready or what?
sister, I've told them, I've asked them to share their screen. Group 19 members, please share your screen.
But we've been here for like 10 minutes and nobody is talking. Please, I've asked Gifty to moderate for me, so I'll call her the respect. If she's telling you to share your screen, please share and then let's start. Okay.
Please, do we have group 19 members here? Please, if group 19 members are not ready, please group 20, share your screen.
I'm not sure. I'm not sure.
Yes.
Please, can you
Hello?
share group 20 our screen for us?
No, sister, please, I can't.
Sisters, group 20. We are putting our work in the group. Please, someone should share for us. What is?
Yes.
Really? Group 20, our work is on the page. Please, someone should share for us. Hey, I can't see you. It's okay now. Sisters, please, good morning.
Morning.
I'm Gagbe Janet, a member from 20. I'm Gagbe Janet, a member from Group 20. We are presenting on spinal bifida.
Hi.
Mute yourself.
So I'll take you through the definition, the biology and physiology. Please mute yourself. And then the types of spinal bifida. So definition. Spinal bifida is a birth defect where the spine and the spinal cord do not develop properly. It is a type of neural tube defect that occurs when the neural tube fails to close completely during early pregnancy. Or we can add spinal bifida is a congenital neural tube defect in which there is incomplete closure of the vertebral column and membrane surrounding the spinal cord during early embryonic development, usually within the first 28 days of pregnancy. Results in varying degrees of spinal cord and nerve damage. So we are saying that spinal bifida is a congenital neural tube defect. What this means is that in Hello, sisters. Oh, my network took me off there. Please, can you hear me? Yes.
Yes, please.
Yes, we can hear you.
Okay. So I was saying that what spinal bifida simply means is that it's a neural tube defect. And then we are saying that in early fetal development, the ectoderm, which is the outer layer of the fertilized egg, it starts to develop a ridge. And then this ridge eventually becomes the neural tube. Then this neural tube grows to become the spinal cord, the brain, as well as the tissues that come in place to protect them, known as the meninges. So spinal bifida occur if the portion of this neural tube fails to close completely at the lower back. Please, let's move to the next slide. Next one. Embryology and pathophysiology. During normal development, the neural tube closes by the 4th week of gestation. So failure of closure at the caudal end leads to spinal bifida. The severity depends. So as I've already said, the neural tube forms the brain and then the spinal cord. And then during the embryonic development, it has to close by the 4th week of gestation. So when it doesn't close or it fails to close completely, it leaves a gap or an opening in the spine. And then this gap can affect the vertebra, the spinal cord, and then the nearby nerve. So depending on the severity, it can involve the meninges, the vertebra, or the spinal cord. And then we all know how important this meninges, the vertebra, and then the spinal cord is. So a quick recap. The meninges, they are 3 protective membranes. They surround the brain and then the spinal cord. And then their function is to provide a structural support, cushion the brain and then the cerebrospinal fluid. And then they also form a barrier against pathogens. Then when we take the vertebra too, it is the vertebra that protect the spinal cord, supporting the body's weight, facilitating movement, and providing structure attachments for muscles and ligaments. And then the spinal cord too transmits nerve signals between the brain and the body for movement and sensation. So we are saying that 1, failure of the neural tube closure, there can be a vertebral arc defect. And then 2, it may involve the meninges only or meninges plus the spinal cord. And then 3, nerve damage lead to motor and sensory deficits below the lesion. As I said already, the spinal cord, it is the spinal cord that transmits nerve and signals between the brain and the body for movement and sensation. So if there is a defect and then the spinal cord is involved, there will be this damage will lead
Janet, please continue.
Oh, sister, sorry, my network is not favoring me. So I was talking about the point 4, chiral 2 malformation, and then how the hydrocephalus will come about. So the chiral 2 malformation is when the brain stem and then the cerebellum are pulled down into the spinal canal, blocking the normal flow of the cerebrospinal fluid. This blockage will cause a fluid to accumulate in the brain and then causing pressure. So that is how the hydrocephalus will occur. Please move on to the next slide. So we are moving on to types of spinal bifida. So with the types, we have 3 types of spinal bifida. So the first one is spinal bifida occulta. It is the mild form. It is the mildest form. Small gap in the spine with no opening or sac on the
Janet,
So we
continue.
have some okay. We have some features that will help you know that this is a spinal bifida occulta or
Host, please. Janet is the one doing the presentation, please. Janet, continue.
They have removed her.
Sister, please have admit her back. Sister Janet, please continue. Group 20, please.
so I was talking about the spinal bifida occulta. So I was saying that there are some features that will help you to detect or know that this is a spinal bifida. It is the mildest defect in the vertebral arc. 3, no protruding sac. 4, often asymptomatic. 5, may show skin signs or dimple, hair tuft or birthmark. So with the spinal bifida occulta, when you are doing head-to-toe examination on the baby, you won't see any sac filled with fluid at the back of the baby. And then we are saying that it is the mildest and common form as well. So what you see mostly is the skin signs, that is a dimple, hair tuft, and then a birthmark. So that is about spinal bifida occulta. Then the second one is meningocele. With the meningocele, a sac of fluid comes through an opening in the baby's back, but the spinal cord is not in the sac. The meninges protrude through the spinal opening. 2, there is a fluid-filled sac present. Then 3, spinal cord remains in the normal position. Then 4, neurological deficits are less severe. So with the spinal bifida meningocele, you will see a fluid-filled sac at the back of the baby when you get to the back. But it does not involve the spinal opening. So the spinal cord, that is about the meningocele. So let's move on to the third one. So the third one is myelomeningocele, or the other name is melingomyinocele. It is most severe part of the spinal cord. Part of the spinal cord and nerves form a sac outside the body. So as I said earlier on, it can also become myelomeningocele, open spinal bifida. So with the myelomeningocele, it is the most severe and clinically significant type. The spinal cord and meninges protrude. There is a high risk of associated with phallus. And then 5, it requires urgent surgical. When you are doing head to toe, a fluid-filled sac at the back of the baby. And this one, because it involved the spinal cord, it is the most severe form. And then there is a high risk of paralysis and disability because the spinal cord is involved. And it is the spinal cord that transmits nerve. If it is affected, definitely there will be a paralysis or disability. And then it is usually associated with hydrocephalus, which I've already explained. It requires urgent surgical management. So my sister Antoinette will continue. Thank you.
Sisters, please, my name is Antoinette, and I'll continue with the causes and risk factors of spinal bifida. Here we talked about folic acid deficiency before and during early pregnancy. We all know that folate, which is vitamin B12, it is critical for DNA synthesis and cell division. So without enough folic acid, the neural tube may fail to fuse correctly. And we also talked about previous neural tube defect during pregnancy. Here, couples who have already given birth to a child with neural tube defect has the increased chance of reoccurrence of giving birth to a child having neural tube defect in their future pregnancies. We also talked about family history of neural tube defect. Since a family has a common genes, if neural tube defect runs in a family, it is 100%, or we have a percentage of couples from such families having that condition. Please, I'll combine the maternal diabetes and poorly controlled pre-existing diabetes. Here, maternal diabetes, which is high blood glucose, can cause oxidation and stress and cellular damage, which may interfere with embryonic development and disrupt neural tube formation. Maternal obesity. During pregnancy, we take in folic acid, and with mothers who are obese, it could be that folic acid intake will be normal, but circulating in the system in a obese mothers may be low, which can cause neural tube defects. Then we also have anti-seizure medication. Here, drugs like valproate, they are teratogenic and directly interferes with neural tube development. Therefore, it can also inhibit folate metabolism. Then we talked about hyperthermia, high blood temperature. Since we said spinal bifida occurs in early pregnancies, so high body temperature is very dangerous during the third to fourth weeks of pregnancy, which can affect the developing embryo and also damages developing neural tissue. High blood temperature can also cause cell death. Then the last one will be poor maternal nutrition. Deficiency in certain vitamins can cause malnutrition. So if the pregnant woman is having a poor diet, she may lack some vitamins, that is folic acid, vitamin B12, and zinc, thereby increasing the risk of neural tube defects. Thank you.
Sisters, good morning. My name is Millicent, and I'm going to take the signs and symptoms of spinal bifida.
Position. Preferably prone position is required. Thank you.
Okay, thank you.
Even in the slides, correct?
Hello.
Yes.
Please, sorry, my network took me off. I wanted to know what you add to the sterile gauze in case you want to cover it.
Saline.
Saline. Okay, thank you.
Please, are we done?
We are done.
Yes, please, we are done. We will leave now. Group 21 or group 19, are you ready? If group 19 is not ready, then group 21.
Good morning. This we are group 21 and we are presenting on meningocele. My name is Juliana Santi. So we are saying that meningocele is a type of neural tube defect and also a type of spinal bifida. But then meningocele is one of the less severe forms of spinal bifida. And then it happens during the early fetal development where the spinal column fails to close completely. So known as the meninges, they push out through an opening in the vertebrae. And this creates a fluid-filled sac, which is visible on the baby's back at birth. With meningocele, there's significant characteristics that distinguishes itself from the most severe type of neural tube defects is that the spinal cord itself is intact within the spinal canal and it's not contained inside the external sac. So when you look at the picture, you see that with the vertebrae, the vertebra, there is an opening there, and then this causes cerebrospinal fluid to fill the space there, and then it causes the skin there to bulge. So we are saying that meningocele is a condition where the protective layers around the baby's spinal cord sticks out through a gap in their spine, and then it forms a bulge or sac on their back. And it is expected during early fetal development. Because this is not a serious type of spinal bifida, we say that it rarely causes long-term or serious medical issues like paralysis or sensory loss. And then it is treated within days after the baby is born with by surgery. My sister will take us.
Good morning. Please, we will talk about the features or the characteristics. We have the protrusion. A sac-like cyst forms on the back filled with cerebrospinal fluid and meninges. We will talk about the location. Mostly, it occurs in the lumbar or sacral region. And we have the neurological features. It's often less severe, but can cause complications depending on the size and the location. Hello?
The next slide, please. So we have types of meningocele. We have two types. We have the open and then the closed. With the open one, there is no skin covering the sac. That sticks out of the opening in the child's spine. And then with the closed type of meningocele, there is a very light, translucent skin covering the sac that sticks out of the child's spine. Meningocele can also occur in different spinal regions, hence they are named based on the locations. We have the occipital meningocele, which is found at the back of the head, the lateral thoracic meningocele found at the side of the chest, the sacral meningocele, which is at the lower back or at the sacrum. So the pictures on the screen shows the various type of meningocele based on the locations. So with the pathophysiology of meningocele, as we already said, it develops due to the failure of the neural tube to close properly during the early stages of fetal development. And then the neural tube, it forms between 18 to 28 days of embryonic development, and failure to close at a point leads to this neural tube defect. In meningocele, the defect is limited to the vertebral arcs allowing the meninges, that is the aura and then the arachnoid, to herniate through the defect, causing a cystic sac filled with cerebrospinal fluid, as we already said in the introduction. So the inability of the vertebrae to close causes the cerebrospinal fluid to form a bulge sac or a fluid-filled sac, which is visible at the back of the baby at birth.
So I'll take it from here. With the symptoms and causes, fluid-filled lump or sac on your baby's back, as my sister already said. And we are saying the symptoms aren't common with this condition, but they may include back pain, changes to the sound of their cry, coughing, fluttering the heartbeat, muscle weakness, shortness of breath or difficulty breathing, and trouble swallowing. Please, next slide. Meningocele causes, like other types of spinal bifida. This condition is a neural tube defect. As we said in the introductory phase, the neural tube is an embryonic structure that develops into the brain and spinal cord. In meningocele, the spinal cord itself develops as expected, but the bones of the spine, that's the vertebrae, don't close completely. This leaves a gap in the spinal column. The meninges, that's the protective membranes covering the spinal cord, therefore push out through this gap, forming a fluid-filled sac. This sac contains the cerebrospinal fluid. As a result, the sac sticks out from the child's back. Risk factors. Research suggests that women with certain chronic conditions like diabetes or who take certain anti-seizure medications may have an increase. Please, next slide.
My name is Abigail Amwatin, and I'll be taking us through the diagnosis and test. So the healthcare provider may see signs of this condition while doing routine prenatal blood and urine tests, but usually they will diagnose it after your baby is born. Providers typically take imagining tests to confirm a diagnosis test. So what this is trying to say is that this condition is often diagnosed after the baby is born, but early screening will help during pregnancy to give early clues. So in this situation, we use this non-invasive imagining like MRI and ultrasound to confirm it. So when we talk about non-invasive imaginary, it basically refers to a medical test that help create pictures of the inside of the baby or an individual without necessarily going into the body or inserting any instrument into the body. So first of all, we'll talk about the magnetic resonance imaging scan. So with this, it uses strong magnets and radio waves. It helps to create detailed pictures of one's brain and spinal cord and tissues. The most important thing here is that it is not harmful to the woman because there is no radiation involved. As midwives, you all know the effects of radiation during pregnancy. So with this test, there is no radiation involved, so it is
Please
safe.
take your time. Benevolence, take your time.
Okay. Thank you. So we will talk about ultrasound scan. So with this, it helps create images of the baby, which also helps in detection of the meningocele. So it provides detect it if providers detect this condition in the fetus, they may recommend a cesarean section. The main reason for doing the cesarean section is to prevent damages of the nerves. So we have the maternal serum alpha fetoprotein. So with this text, it is usually done within the 16 to 18 weeks of pregnancy. Someone will ask about the alpha fetoprotein. So with this, we all know that the baby livers produce protein. So mostly some of this protein will crosses and goes to the mother's bloodstream. So we can use the mother's blood to detect this alpha fetoprotein. So when there is high level, it can show that the babies have a defect in its tubes. Please, let's continue. When we talk about treatment or management of meningocele. So we first of all talk about the immediate care after birth, which says that protect the sac by covering it with sterile dressing to prevent infection. So the main reason for the immediate care is to want to stabilize the baby and to prevent infection. So with the prevention of infection, we all know that this sac that we are talking about contains cerebrospinal fluid, and it is delicate to meninges. So if it is exposed, we all know that exposure can cause bacteria to easily enter, which will cause sepsis. And we all know that sepsis can be life-threatening to the baby. So with this, it says that you have to cover it with a moist, sterile gauze or something. The main reason that we are covering with a moist, sterile is to prevent cracking. Because if the sac surrounding it is dried out, the membranes can crack and it rupture. So when it ruptures, it can cause a risk of leakage of cerebrospinal fluid and infection. So the main reason why we cover it with a moist sterile gauze is to prevent the nerves. So definitely, if you are preventing cracking, that means that the nerves surrounding the sac will be protected. So we have surgical repair, which is the primary treatment. So with this, the main goal of the surgeon is to see to it that he closes the opening in the spine and protects the spinal nerves. So it is the duty or the responsibility of the surgeon to see to it that the nerves are not So it says that other treatments include post-surgical care to help monitor the baby and prevent infection. Involving and educating relatives on condition also helps prevent this condition. We all know that in such cases, when the relatives see such condition, they become threatened and something like that. So you have to educate the family. We have to involve them in the care so that it will help in the healing process of both the mother and the baby, especially the mother psychologically. If you involve the family in the care, especially on infection prevention, it will help the baby heal perfectly and prevent further infections. Thank you.
So please, I'm Emmanuel saying I'm continuing from complications of meningocele. Complications may include 1, increased intracranial pressure. So with the increased intracranial pressure, most babies with meningoceles have an associated brain malformation called carotid malformation.
Anigye no, ebi sɛ Nyankopɔn ɛnyɛ obiara na ɔde anigye no bɛma no. Aha.
So I'm Emmanuel was saying I'm continuing from complications of meningocele. Complications may include 1, increase in intracranial pressure. So with the increased intracranial pressure, most babies with a meningocele have associated brain malformation called carotid malformation. So in the carotid malformation, this is where the lower brainstem and cerebrum are displaced downward into the spinal canal, obstructing the normal flow of cerebrospinal fluid. So this can lead to what? Hydrocephalus, that is excess fluid in the brain ventricle, which rises what? Intracranial pressure. 2, we have what? Infections. So infections is one of the most dangerous complications in a child with a neural tube defect. Examples of the infections is what? Shunt infection, meninges, urinary tract infections, and others. And we have paralysis. With the paralysis, child with the neural tube defect is primarily determined by the levels of the spinal lesion. In meningocele, the spinal cord and the nerves are exposed and often malformed. The higher the lesion on the spine, the more extensive.
Please, you are moving fast.
Okay, and we have problem with bowel and bladder control. So because of the meningocele at the sacrum or at the back of the baby, it is difficult for the baby to poo or something like that. And we have threaded spinal cord. In a child who has undergoes surgical repair of a meningocele, the spinal cord can become abnormally attached at the site of the original closure. As the child grows, the spinal column elongated, but the face cord cannot extend normally, leading to progressive stretching of the lower spinal cord and nerves. And we have lastly mild motor or sensory deficit. In this case, the true meningocele and the spinal cord is normally positioned. There can be subtle neurological deficit. Thank you. My colleague will continue.
Sister Emanuela, please, we didn't hear anything. You were just moving too fast.
So should I take it again?
Yes, but this time around, calm down.
Okay. So complications of meningocele. Complications may include 1. Increased intracranial pressure. And as I said earlier on, babies with a meningocele have an associated brain malformation called CARI2 malformation. In this CARI2 malformation is whereby the lower brainstem and the cerebrum are displaced downward into the spinal canal, obstructing the normal flow of cerebrospinal fluid. This leads to hydrocephalus, and we all know that hydrocephalus is excess fluid in the brain's ventricle, which so with this it will increase the intracranial pressure. 2, we have infections. Infections is one of the most dangerous complications in a child with the neural tube defect. And we have a lot of infections. We have meninges, shot infections, wound infections, and urinary tract infections. And we have paralysis. So with the paralysis is a child. So paralysis is a child with the neural tube defect is primarily determined by the levels of the spinal lesion. In meningocele, the spinal cord and the nerves are exposed and often malform. So the higher the lesion on the spine, the more extensive the paralysis occur. And we have problems with bowel and bladder control. And we have treated spinal cord. So with this one, in a child who has undergoes surgical repair of the meningocele, the spinal cord can become abnormally attached at the site of the original closure. As the child grows, the spinal column elongated, but the face cord cannot ascend normally, leading to progressive stretching of the lower spine cord and the nerves. And lastly, talk about the mild motor or sensory deficit. And in this case, true meningocele and the spinal cord is abnormally positioned, thereby can be subside neurologically defect. In meningocele, deficits are more common but can still be mild depending on the levels. My sisters will continue from there. Next slide. Prevention of meningocele. Meningocele, like other neural tube defects, cannot always be prevented, but the risk can be significantly reduced with poor maternal health measure before and during pregnancy. 1, we have folic acid supplements, and we all know that during
Prevention
pregnancy.
of meningocele.
Hey, Manuela, we can't hear you.
Someone will continue, so I have stopped.
Benevolence and Pokia, please, we are waiting for your members.
Ella, where are we?
Prevention of meningocele. Meningocele, like other neural tube defects, cannot always be prevented, but the risk can be significantly reduced with proper maternal health measures before acid supplementation. Daily intake of 400 micrograms of folic acid is recommended for all pregnant women or women of childbearing age. Women with history of neural tube defects in previous pregnancies may need higher doses, 4 to 5 milligram daily under medical supervision. Next slide, please. So supplementation starts at least 1 month before conception, and then you continue throughout the first semester. And then secondly, the woman needs to take balanced diet. Balanced maternal nutrition is also very important. Adequate intake of foods rich in vitamin B12, zinc, and then iron supports neural tube development. 3, lifestyle. Avoidance of risk factors. There should be a limit to exposures to teratogens such as alcohol, smoking, and then certain medications. Thank you. Please, we are done.
Please, any question?
Please, any question for them? For them. Patient J wants to answer. Benevolence 2 wants to answer. Please, any question for them?
Not why they were damper.
Group 22, please, you have only 20 minutes to present. Sister Betty.
Yes, yeah.
Sister, please, should we continue? I think we have
Yes.
only 20 minutes to end the class.
Let them start. And
Okay.
Felicia, I don't think it should be that voluminous.
Okay. Group 22, please kindly share your screen.
Gifty, does class end today?
It ends on 5th April.
Okay.
Hello, sisters. Good morning. Please, we are trying to share our screen, but we can't. So I'll forward it to the WhatsApp page. Can someone please share for us? Good morning.
To them.
Hello, this is Anochwa. Please, can we present while someone tries to share? We are unable to share.
Gitwahini, please let me share your slide for you.
Okay, sisters, thank you. Sisters, please, good morning. We are group 22. We are presenting on encephalocele, and I'm Florence. Encephalocele is a rare type of congenital neural tube defect, which is characterized by sac-like protrusion of brain tissues. It could be either the meninges, that's the membrane covering of the brain, or just the brain tissue. And is a Greek derived from a Greek word, the encephalos, which means brain or within the brain, and the cell meaning swelling or hernia or tumor. Please, the next slide. With the types or the classifications, it was classified by Suwanwela, and he did it according to the location of the encephalocells. So based on where it is located, then you will get the types. So we have the occipital encephalocele. That is 75% of the cases, which is more common. We have the sincipital. We have the frontoethmoidal encephalocele. We have the nasoethmoidal. We have the nasofrontal, the nasoorbital, interfrontal encephalocele. And we have those that are associated with the craniofacial clefts. With the continuation of the classification, we have the parietal encephalocele, we have the basal encephalocele, intrasphenoidal, we have the temporal. With the epidemiology, they are thought to occur in one of every 4,000 live births. It's not that's really common, with the frontoethmoidal encephaloceles being the common one and mostly found in the South and the Southeast Asian populations. With the causes or the risk factors, the etiology or the exact cause is unknown, and it is multifactorial. It could be genetic or environmental. So we have some risk factors. So with the encephalocele is when the neural tube fails to close during embryogenesis or embryology within the first 21 to 28 days. That's 3 weeks to 8 weeks of gestation. The risk factors are associated with folate deficiency, maternal diabetes, infections, teratogens, genetic syndromes such as the Gruber or the Knobloch. They are associated risk factors that can cause encephalocele. With the Gruber syndrome is a rare lethal multisystem disorder with a variable phenotype that's characterized by multicystic dysplastic kidneys and central nervous and hepatic abnormalities that can also cause the encephalocele. Associated anomalies could be hydrocephalus, microcephaly, spinal bifida, and agenesis of the corpus callosum. Just like we said, is a type of a neural tube defect. So the spinal bifida, the baby or the affected child could have these anomalies associated with it. Then some certain medications, such as anti-seizure medications, could also be a risk factor. that could cause encephalocele. With the pathophysiology, encephalocele, when congenital, that's the most common. It could happen due to trauma or some other causes, but with what we are talking about the congenital one. So when it is congenital, it is mostly associated with the neural tube defects and occur due to failure of the fusion during embryogenesis. That is the 21 to 28 days post-conception of the cartilaginous neurocranium, the membranous neurocranium, or the visceral cranium during gestation. With a clinical presentation, it is visible at birth. So you see a sac-like mass or scar. The sizes varies. It could be small, it could be big. And the location, just like we have said, it could be occipital, anterior. And based on where you find the location, the type or the classifications are being given. And it may also cause neurological deficits. When it is at the anterior or the nasal or the midline nasal or forehead, there could be airway obstruction, and you could have cosmetic issues and leakage of the cerebrospinal fluid. With the symptoms, there could be seizures, you will have developmental delay, hydrocephalus, you could have vision or hearing issues, and infections. That is in the case where the meningitis is ruptured. And the severity too could be mild or to life-threatening. That is when there is a large brain herniation or large brain protrusion or swelling. It could be, with a diagnosis, it could be diagnosed prenatally through ultrasound scan. That is during routine screening, anomaly scan when it's taken. And during the ultrasound, it could be seen as a purely cystic mass or may contain echoes from herniated brain tissue. If the mass appears cystic, the meningocele component predominates, then in that case, we would diagnose it as meningocele and not encephalocele. And when you see a solid mass, it indicates encephalocele. Larger encephaloceles may show accompanying microcephaly. So the larger the protrusion or the swelling is most likely accompanied by microcephaly. Postnatally too, on physical examination and MRI and CT imaging should be done for detailed assessment. And MRI is the best imaging modality for defining the contents of the encephalocele. That is for detailed assessment and prior to surgery. The CT may also be used to display the bone anatomy, but the intracranial connection is best defined with the magnetic resonance imaging. The extent of the cerebral tissue in an encephalocele is also better defined with the MRI imaging. We have a differential diagnosis. Presence of swelling or herniation could either be a dermoid cyst, a nasal glioma, or a meningocele. With the treatment, the primary treatment is surgical repair, and the goal is to close the skull defect, reset non-functional herniated tissue, to prevent infections and leakage of the cerebrospinal fluid, and also achieve a good cosmetic outcome. The timing for the treatment or the surgical repair is ideally in infancy, when the skull is flexible. With the treatment, it requires a multidisciplinary approach. So it should involve a neurosurgeon for the brain or the nerves side, then plastic surgery for the cosmetics. You should have a pediatrician. Genetics are also involved. Then supportive care for seizures or developmental issues. There is no medical cure to encephalocele. The prognosis depends on the size, the location, the brain tissue involvement, and associated anomalies.